also want to take just a second to apologize for, during the presentation, I'm going to have to toggle between a couple of different screens because I want to play 2 videos. And with Teams, I haven't been able to figure out quite how to do that seamlessly. So I apologize ahead of time for that process. So we'll get started. Here's the CME code. I'll show it again at the end in case anyone comes later or didn't have time to enter all the information. Today's talk is going to be on trauma-informed care. I'm Lizzie Hovis. I'm a third-year psychiatry resident at the University of Pittsburgh Western Psych. I'm originally from Wisconsin, which is also where I did my medical school. I did undergrad and medical school there, lived out east for a little bit, about 4 years, and then went back to Wisconsin for medical school. So I spent a lot of time in Wisconsin. Ever since starting residency, I've been incredibly interested in women's mental health and trauma, and I found that that perinatal care actually brought about the intersection of those 2 interests. And trauma really came about for me because I realized that the majority of the patients I was working with had a pretty significant history of trauma. And as I spoke with colleagues in different specialties who weren't even in psychiatry, they also had patients with a lot of trauma in their history. And so I just realized that I wanted to be proficient in a trauma-informed lens. In addition, a reason that I'm excited to be here with you guys is I have a 9-month-old. Last August, I had an epidural for that delivery, and then I also had a fairly urgent C-section. So I am incredibly grateful for OB anesthesia and what you guys do. And we are expecting our 2nd daughter in November. So I, again, am grateful for you guys and your career. So thank you for what you do, and thank you for being here today. What we're going to go over today, so learning objectives. I'll talk about trauma. I'll define trauma, and there's lots of definitions of trauma, but I'll talk about some that really hit home with me. And then we'll discuss the 4 R's of trauma, which is a good framework for understanding it. We'll review the prevalence of trauma. We'll explore how trauma can manifest specifically in a perinatal population. And then perhaps most relevant to this talk is going over ways that OB anesthesiology can implement trauma-informed care into their daily practices. The 4 R's of trauma are a framework developed by SAMHSA that supports the implementation of a system-wide trauma-informed practice. They're realize the widespread impact of trauma, recognize the signs and symptoms of it, respond by integrating that knowledge into our practice and procedures, and resist re-traumatization. Today, we'll focus on the realize, the recognize, and the resist. While there certainly are ways that OB anesthesiology can respond and integrate what we learned today into daily practices, that actually the onus of the response falls on UPMC as a system and McGee as a hospital. Those have to be system-wide approaches to integrating the trauma-informed lens into an entire system in order to make a system-wide practice. So what is trauma? There are, like I said before, there are lots of definitions of trauma floating around out there, and I think a lot of them are very good. What matters to me is that it's a broad definition encompassing a wide range of experiences, and that it points on the fact that something that is traumatic to one individual is not necessarily going to be traumatic to another individual. So I like this definition. It's an event or set of circumstances experienced as physically or emotionally harmful or life-threatening that overwhelm an individual's ability to cope. And Bessel van der Kolk is a psychiatrist. He's a pioneer in the field of trauma. He wrote The Body Keeps the Score. And he conceptualizes trauma as an injury, a wound, something that happens that's too big for one's mind to comprehend. When we in the medical field think about trauma, we often think about medical trauma or a traumatic injury, and that's defined as a sudden or severe injury necessitating acute medical attention. And while medical trauma certainly is an example of psychological trauma and can lead to long-standing psychological trauma, the trauma itself encompasses a far broader range of experiences. Here are some examples. In psychiatry, and I think in other specialties, when we think about trauma, we think about the social history screen, and there's three big ones that we usually touch on the social history screen. That's whether someone has a history of emotional trauma, sexual trauma, or physical trauma. So these are mentioned here, but in addition, there are other things. There's neglect, there's living under racist systems, there's terrorism, man-made or natural disasters, loss or grief, living with homelessness, food insecurity, receiving a terminal diagnosis. And in addition, I'm sure everyone on this call has experienced or knows somebody who's experienced something traumatic that is not really on this group. If we focus specifically on reproductive perinatal trauma, then that doesn't necessarily narrows the scope, it doesn't narrow the list. So there's a lot of things that can be experienced as traumatic and lead to long-standing trauma-related symptoms that women that we work with every single day will have likely encountered. So things like unplanned pregnancy, maternal or fetal complications either during or after pregnancy, the current pregnancy or past pregnancies, history of pregnancy, loss, stillbirth, a labor history. If someone had an unplanned C-section or an instrumental vaginal birth and that wasn't in their idea of what a birth looked like, or what they wanted, or what their birth plan looked like, that can be traumatic. A prolonged labor, painful labor, history of infertility, history of perinatal mood or anxiety disorders. So perinatal trauma itself has a lot going on. And like I mentioned before, trauma is incredibly prevalent. So the majority of people will have experienced trauma in their lifetime. The most recent stat I found is that 70% of people will have experienced greater than or equal to one traumatic episode during the course of their life. If we narrow that down and focus on the perinatal population or women that you all work with, about 25 to 34, so about 1/3 of women will classify their childbirth as traumatic, which is a significant amount. PTSD occurs in 10% of women in their lifetime, and then the reproductive years have always been thought of as this kind of high potency time for trauma-related symptoms, exacerbating history of trauma, or predisposing women to trauma. This is seen with pretty high prevalences, 4 to 6% of pregnant women being diagnosed with PTSD and 4% of postpartum women being diagnosed with PTSD. Like I said, the reproductive years are really, ripe times for PTSD symptoms to come about. And the reason that this is likely multifactorial. There are lots of hormonal, physiological, and physical changes going on in pregnancy that can lead to worsening mental health. That can lead to worsening PTSD symptoms. In addition, depending on a woman's history of trauma, that can really be exacerbated in pregnancy. If someone has a history of childhood trauma, for instance, thinking about becoming a parent is not necessarily a very joyful or wholly good thing to think about, and they can have fears related to that, panic related to that, feeling a lot of inadequacies related to that. If someone has a history of sexual trauma, routine prenatal care, labor with regular cervical exams can be especially triggering. And then in addition, many women with a history of PTSD could have been well managed on medications like SSRIs and will discontinue those medications during pregnancy for fear of harm to the baby. What are symptoms of PTSD? Broadly speaking, the three main symptoms of PTSD are re-experiencing, which is what we think of when we think of things like nightmares, flashbacks, excessive remembrance of the event that was traumatic, avoidant behaviors as a response to that re-experiencing, so avoiding people, places, things, smells, words that will bring about those re-experiencing or that remembrance of the event. And then lastly, hyperarousal. We often refer to this as hypervigilance or feeling keyed up and on edge. If you can remember those three main symptoms, that will pretty much embody what PTSD is. However, the way those three symptoms will manifest in a perinatal in any individual will change depending on that person's circumstances. So specific to the perinatal population, you could have a lot of different manifestations, but I included some on this slide. So limited prenatal care, or entering into prenatal care very late in the pregnancy, using substances throughout pregnancy despite understanding the risks of such, refusing portions of a physical exam throughout perinatal care and then during labor, interpreting neutral or benign stimuli as very painful or dangerous. And then what we would see perhaps on the other side of it is excessive anger, irritability, panic in situations that other women would not likely show those emotions. This is going to be the first part where I toggle to a different screen. I want to show my first video kind of diving into why this happens, and then we can go back to that slide. I'm just going to stop screen sharing for a second, and then we'll go back to that.
A primary function of the amygdala is to sense danger. When it does, it sounds an alarm, alerting the body and initiating a neuroendocrine cascade with one goal in mind: survival. The three types of survival responses are fight, flight, or freeze. When it is a matter of survival, these are normal and appropriate responses to abnormal, life-threatening situations. However, in an individual with a history of trauma, the survival response is perpetually turned on and becomes an abnormal response to normal situations. While the neurological and psychological effects of trauma are many, there are three ways that the brain evolves to cope with trauma. The first is that the threat detection system is exaggerated. This results in an individual interpreting benign or neutral stimuli as dangerous. Second, the brain's filtration system, or selective attention, is impaired. This makes it difficult to distinguish meaningful stimuli from insignificant details. In other words, an individual with a history of trauma may focus on things that others are able to ignore. That prevents them from paying attention to what really matters and makes it nearly impossible to be in the present. Finally, the midline structures of our brain provide us with self-sensing mechanisms, or interoception. This gives us an awareness of body-based feelings. For people with a history of trauma, however, there is a constant barrage of feelings of danger. In order to protect themselves, they silence their self-sensing system and therefore respond to stress in one of two ways: spacing out or panicking and reacting with anger. In summary, while a traumatic experience may be short-lived, the neurological and psychological effects can last a lifetime. Having an understanding of the brain's response to trauma allows us to implement a trauma-informed approach to better work with and care for individuals with a history of trauma.
All right, so then if we go back to that slide, let's see if I can get back to it. So let's go back to the slide we just looked at. If we think about what we just saw in that video and how the brain will respond to trauma in order to better be able to cope with the symptoms of trauma, and we look at the manifestations of trauma in a perinatal population. Let's just take, for instance, the first point, so limited prenatal care. I have a very close friend who's an OBGYN, and in her practice, she says that they often refer to women who do not attend prenatal care appointments as DNAs, or do not attend. I think it's fairly common in medicine to label patients as like non-adherent or non-compliant or difficult patients when they exhibit a lot of the symptoms that are included on this slide, and that's probably a natural way of expressing our frustration, especially when there's a complication that arises that we know could have been avoided had the patient engaged in recommended care. So I do think it's our way of coping with that, with those behaviors. At the same time, if we consider that video, we can see that women with a history of trauma, there's likely some reason underlying behaviors like limited prenatal care, perinatal substance use, refusing physical exam. And if that reason is a history of trauma, perhaps someone doesn't want to engage in prenatal care because the environment, the hospital or clinic environment is going to be particularly triggering to her, or there's a history of perinatal or reproductive trauma that brings about a lot of re-experiencing. And so that could just be a manifestation of avoidance. And I think it's by thinking about it that way, by stepping back and considering that, it allows us to shift the lens from what is wrong with this patient, which is our natural instinct, to what happened to this patient. And if we shift the lens in that way, we are so much better positioned to support our patients, and it will likely lead to better outcomes. Going on, like I talked about in the definition that I liked about trauma, what is traumatic to one woman is not necessarily going to be traumatic to another woman. Two women could have objectively very similar birthing experiences, and one could experience that subjectively as traumatic while the other does not. Why does that happen? Like everything with medicine, there are risk factors and there are protective factors. With trauma, those protective factors are usually called resiliency factors. Perinatal depression, fear of childbirth, poor baseline health and or health complications during pregnancy, history of PTSD, a negative subjective birth experience, operative birth, or lack of support during birth are all risk factors for postpartum PTSD. Resiliency factors, on the other hand, positive emotion, active coping, social support, and having a sense of purpose or meaning. So, someone who's able to think of things through a positive lens, even when they're stressful, rather than go straight to a negative lens, is more likely to be resilient and not develop PTSD, even if they experience a traumatic experience. And when we look at this list, what I also think it's important to consider what is in our control and what is not in our control. Are any of these things modifiable? For risk factors, not much. Perhaps lack of support during birth could be something that OB anesthesiology or medicine may be able to modify if that definition includes the support from hospital staff or the medical team in addition to just support from family and friends, which I'm sure it probably means more so social support. In terms of modifiable resiliency factors, I think we could all make a case that 3 out of 4 of these are modifiable in some way. At least 2 of them are definitely modifiable. So increase positive emotion, help kind of shift the lens from a negative to a more positive perspective of the event. And then also we have the potential, especially in OB anesthesia, where you're going to be up right by the patient's head, you're going to be talking to her throughout it, kind of exploring, if you're a possibility, a sense of purpose or meaning. What are you most excited for about bringing your child home? What are you most excited for about being a parent? Things like that not only distract from an acute emergency, but may bring about a sense of purpose and meaning for the patient and kind of remind her why she's going through this thing that's probably very acutely scary for her. Resiliency is interesting. There's been a lot of studies on it, usually developmental studies, that are promising. So children who are most reactive to stress or respond to stress with traumatic responses in a negative environment will have very negative outcomes. However, children who are most reactive to stress and respond to with traumatic symptoms in a positive environment actually show the best outcomes. I wonder if this research could translate to the perinatal population in the birth environment, such that are we able to bring about resiliency with those modifiable factors I just talked about? Can we do things like increase positive emotion, increase optimism, support the woman, and offer a sense of meaning or purpose in order to improve outcomes and decrease the risk of postpartum PTSD? I'm not sure, there hasn't been research done on that, but I wonder if it would translate in that way. So how do we do this? How do we decrease the risk of postpartum PTSD, avoid re-traumatization, and ideally improve resiliency in the patients that we're working with? This brings me to the universal steps that OB anesthesia could take when working with every woman. And I want to point out something that I think everyone who is present for this talk probably does all of these things already. And I can say that the anesthesiologist who took care of me last August certainly did everything on this page, though not in this order, and the order is not important. I simply made it into a mnemonic or an acronym because that allows people to bring it to mind easily and just ensure that we're incorporating a trauma-informed lens. And it's also helpful for bringing new trainees into the field to stress the importance of trauma-informed care. But again, I think you guys do these things naturally. You do them in an order that makes sense. That's probably more intuitive than this slide, but I just wanted to put it in a helpful, memorable way. So I use the acronym MIRROR when I'm thinking of the perinatal trauma toolkit. M is for make eye contact and introduce yourself. I is for informing the patient about what's happening and, if possible, offering her treatment choices. I know that's not always going to be possible or safe. R, reassure the patient that you or someone from your team will be with her throughout the entire process, whether that's an emergency, a C-section, the epidural placement, things that you know are obvious, but she may not recognize that. Recognize possible fears and worries in the patient. So if she feels acutely anxious to you, she seems acutely anxious, recognize what she could possibly be worrying about, or even, I think it's fair to ask her if she agrees that she's not posing that you could help explain. Offer reassurance and realistic hope, and regularly assess and treat pain. This is where I'm going to stop screen sharing again and pull up the second video, so bear with me.
Women who experience complications during labor are at an increased risk of developing postpartum trauma-related symptoms and responses, regardless of whether they have a history of prior trauma or not. This can be due to a variety of reasons. For starters, women may perceive complications as threatening to either her own or the baby's well-being. Also, in emergency situations, there will be many medical responders from a variety of specialties, which can cause confusion and concern with the patient. Finally, severe pain and other physical symptoms can trigger or intensify the body's threat detection system. Because of that, it is critical to utilize a trauma-informed approach in settings like unexpected C-section or an emergency team response. In doing so, we can minimize the risk of triggering or re-traumatizing an individual with a past history of trauma, as well as mitigate future trauma-related symptoms in women who experience the labor complication as traumatic. Fortunately, incorporating a trauma-informed lens does not require additional time, and it is likely that you are practicing many of these steps already. By using MIRROR, we can quickly bring to mind a set of tools that will minimize trauma-related symptoms. Let's see this in action.
Hello, my name is Dr. Maxwell. I'm your anesthesiologist. We're running your C-section because the baby's heart rate was increasing during labor. The procedure itself will take about 30 minutes. You may feel nausea from the pain medicine. Please let me know if this is the case and if you would like medicine for that. I'm going to be right here the entire time. While I know that this can feel scary, you're in good hands. We are monitoring you closely and everything looks good so far. While you should feel pressure, you should not feel pain. Are you feeling any pain? If you begin to, just let me know and I can give you more pain medicine.
You can see that standardizing the trauma-informed process does not add extra steps nor time toward intervention. Instead, we can weave mirror into the approach we are already taking, and in doing so, protect against re-traumatization and long-standing trauma-related symptoms.
So I know in that video we kind of zoomed through mirror, but and we zoom through each of the steps, and it doesn't really pause between each step. We'll have an opportunity in a second to go through a couple of cases and think about ways that we can incorporate some of the steps, if not all of them, obviously into the patient care. And if all else fails, everything we've talked about with MIRROR is actually thinking about the neocortex, higher order thinking, trying to bring the neocortex online and engage the patient's thinking brain in the acute stress response. But if that's not working and the patient feels to you like she's acutely anxious, distressed, overwhelmed by the circumstances, an additional Hail Mary tool that really anyone can use and that you guys are likely experts in because of your role and what you work with every single day is targeting the limbic system and targeting breathing. We can guarantee that a woman in an emergency obstetric situation is going to be in a high arousal state, that her physiologic alarm system is going to be going off. That's going to be activating the sympathetic nervous system. She's going to have shallow, rapid breathing, and it's just going to continue to perpetuate that high arousal state. By encouraging breathing, encouraging diaphragmatic breathing, whether it's on the way from the labor suite to the operating room, or while you're giving her oxygen, or while another intervention is taking place and you're simply standing at the head of the bed, kind of talking her through, working with her, assessing her pain, you can encourage deep breathing. And that not only shifts her from passive role where something is happening to her, but to an active participant, it also reverses the response by bringing the parasympathetic nervous system online. So we saw the video, it zoomed through some example of using MIRROR in practice. I wanted to take the last couple of minutes to just go over very briefly a couple of what I imagine to be common OB anesthesia cases. So the first is we have a 29-year-old female. She's G4P0 with history of recurrent pregnancy loss. She was admitted to McGee for planned induction at 37 weeks for preeclampsia. Anesthesia was called for an epidural. And the patient appeared acutely anxious, distressed, was breathing rapidly. She was unable to really pay attention to what you were asking her. You were asking very straightforward past medical, past surgical history questions before placing the epidural, and she wasn't really able to engage in that part of the exam. Physical exam findings, her vitals were a little elevated, blood pressure 156/98, heart rate 117, and then she was setting at 95%. So I have the chat function open. It's really up to you guys. If you have answers to this, feel free to just send something through the chat function. If you have questions, the same way. If you'd rather speak, feel free to unmute yourself and speak up. I would be happy for any of that. So what are some signs or symptoms in this very brief example that you see right away that this person could be responding in a traumatic way?
So feel free to use the chat box or to unmute yourself, as Dr. Hovis has said. But so I can start. Dr. Hovis, it seems perhaps she's exhibiting some signs of hyperarousal there, the breathing and blood pressure things, although I'm sure many of the folks on this call have also seen many of those normal responses in non-traumatic labor as well. So not to raise a question for your questions, but could you help us draw some distinctions between normal physiologic responses in labor with pain to a hyperarousal state for a patient who might have PTSD and is re-traumatizing?
Yeah, oh, I'm so happy you brought that up. So that was one of the things we were going to talk about with what steps you can take to improve the experience. You were called to this patient's room to place an epidural. Someone who's in severe pain will probably show vital sign abnormalities that are similar to the ones that we discussed. And if you're called there to place the epidural, by placing it and then re-examining her or checking back in on her in whatever way is normal protocol, you can see if that step alone, which is a step in MIRROR, which is a step in a trauma-informed approach, the reassessing and treating pain, if that alone was enough to kind of normalize those vital sign responses, if she didn't feel acutely anxious or overwhelmed on physical exam anymore, if she was more able to engage in answering your questions, if that was all normalized or improved at least, then it was more indicative of that being secondary to severe pain rather than a history or signs or symptoms of a traumatic response. I think something also that's just important to consider is that in this case, there are a couple of risk factors for postpartum PTSD just to keep in our mind, because I think it's likely that if you're going to help someone by placing an epidural or help someone with severe pain, we could attribute what we're seeing to severe pain. And it's important to just not forget that a history of trauma could be contributing. So are there any risk factors in there that stand out to you that could place her at risk for having trauma-related symptoms during labor or following labor? And I know it's early, so I'll jump in and feel free to interrupt me if you wanted to, if you have questions. But a history of recurrent pregnancy loss and then complications during labor for her, she was diagnosed with preeclampsia, placed her at an elevated risk for developing postpartum PTSD. And just could raise a red flag that what we're seeing may not be only secondary to pain, but may be a trauma response. Dr. Lim, I think your question was really poignant in that if her vital signs are all looking good after the epidural has kicked in and she is saying that she feels better, she's able to answer questions, I think it's much more likely that we can just chalk that up to pain. Much less likely that it's due to a trauma response and that those symptoms would be long lasting. So case number 2, we have a 32-year-old female, G1P0, at 38 weeks and 5 days. She was admitted for spontaneous labor. She requested and received an epidural. Unfortunately, she required a C-section for non-reassuring fetal heart tracings. In the OR, she received 20 milliliters of 2% lidocaine. She was tested with an Alice clamp for the pain control. And she said at that time that she felt pressure and pain, but was told that she was feeling only pressure. When she thinks back on her laboring experience, she recalls having her arm strapped down, feeling pain throughout the procedure, and feeling that no one listened to her, heard her symptoms. In review of her medical record, they can see that there was no further pain medicine given despite her telling the doctor that she felt pressure and pain. This woman was ultimately diagnosed with postpartum PTSD and that necessitated therapy 3 years after her delivery. So risk factors for developing postpartum PTSD, I think a non-modifiable risk factor is the fact that she went to C-section for a complication during labor. That's not anything anyone can prevent. But what about steps that could have been taken to minimize the risk of this woman developing postpartum PTSD? Are there any that stand out to you?
So there's the her overall sense of feeling that she was not listened to in some way.
Yeah, I think that if we think of the acronym, we could kind of like pain seemed to be an obvious concern in this case again. And by assessing and treating the pain and listening to her complaints, it may make her feel as though she's she is in good hands, that she's in a safe situation, that she's going to be taken care of, her concerns are going to be taken seriously. And I think for someone, especially someone who's not in the medical field, to go through an experience like that, it can be the idea of, for instance, going through another labor or getting pregnant again could probably be very triggering and interpreted as traumatic because of this. Other things we could do is, so I'm sure, like I said, that the other steps in MIRA were taken, but I think just focusing on the pain control aspect of things, reassuring the patient and offering reassurance to her, reassurance and realistic hope, and kind of assessing for other worries if there were other things contributing to this. If she's in the OR getting a C-section, perhaps she's worried about whether or not she or the baby will be okay, and assessing for that may be helpful. And that's the rest of the presentation.